Hello, and welcome back to Med-Surg Knowledge Nuggets, where we take big nursing topics and break them down into manageable, test-friendly content. Today we're talking about seizures. All right, so let's talk seizures. Picture this. You're at the bedside and suddenly your patient starts to have convulsions or becomes unresponsive. What's happening? A seizure is essentially the brain misfiring, uncontrolled, excessive electrical activity that spreads like a lightning storm in the brain. But here's where it gets tricky. Not all seizures have the same cause or pattern. Some patients will have seizures after a stroke, brain injury, or tumor, so you'll always need to check on that history. If no cause is found, we call it cryptogenic. Still dangerous, just we don't know what the cause is. Epilepsy is a diagnosis when seizures happen repeatedly. This is something your patients will manage for life, often with daily medications and lifestyle adjustments. You'll need to understand the background to educate your patients, anticipate complications, and explain the why behind seizure precautions. Risk factors and triggers for seizures. What puts our patients at risk for seizures? In the clinical setting, you will see that seizures aren't always from epilepsy. There are a lot of things that can set off a seizure, even if it's just temporary. A high fever in children, classic febrile seizures. Low sodium or hypoglycemia, another example that you'll need to pay attention to the lab values. Alcohol withdrawal. Think about patients who are in detox or post-op who can't have a drink. Head injuries, especially if they just had a fall. Lack of sleep or stress or even flashing lights can trigger seizures in somebody with epilepsy. This is why a thorough history and physical and environmental assessment is key. As the nurse, you will be the one noticing when a patient is more irritable, hasn't eaten, or potentially is withdrawing from medication. Now we're going to talk a little about types of seizures and why does it matter what kind. We break seizures into two main types, focal and generalized. Let me tell you why knowing the type makes a difference. It helps us tailor interventions, communicate better with the provider, and understand what to expect. Focal or partial seizures, only one part of the brain is causing this. Patient may stay awake, but may act strange, like may have chewing motions, staring, or picking at clothes. If it is simple partial, the patient is fully conscious. If it is complex partial, they will have impaired consciousness. Then we have generalized seizures. This is when the whole brain is involved. These are the big seizures. Tonic-clonic, also used to be known as grand mal seizures, involve stiffening, jerking, unconsciousness. So what we want to do is protect the airway, and of course we want to time it. There's also something called absence seizures, which used to be called petit mal seizures. This is common in kids, and it looks like they're just kind of spacing out, kind of like they are daydreaming, and this can be missed if you're not really paying attention. Then we have myoclonic, atonic, tonic, clonic. Each has its own unique patterns, but all require safety precautions. So your nursing relevance here, recognizing the seizure type means you can document accurately, prepare for expected post-ictal phases. Post-ictal means post-seizure, and you'll be able to teach families what to watch for once they go home. Clinical manifestations of a seizure. What do you actually see? In the moment, seizures can look like a lot of things, not just convulsions. So tonic movements include rigid, stiff muscles. Clonic movements are rhythmic jerking. Aura. Some patients can feel a seizure coming on. You want to ask if they've had one after a seizure. Automatisms. This can be lip smacking or picking. These can easily be missed if you're not paying attention. Incontinence or falls. This can happen often with atonic seizures. Your nursing relevance here. You're often going to be the first one to witness or be called to the room with a patient who is having a seizure. You'll need to describe what you saw and not just say the patient had a seizure. This helps the provider, the neurologist, to classify the type of seizure and adjust the medication and interventions appropriately. Moving on to diagnosis, medication, and nursing interventions. What is your role as the nurse? So this is where you come in with both critical thinking and action. So seizures may prompt imaging, a CT or an MRI, to rule out something that we can see in the brain, possibly for example, a tumor. You will be responsible for prepping the patient and explaining why this is needed. Lab work. This is going to help to rule out other causes such as electrolyte imbalances, maybe hypoglycemia, and possibly testing a toxicology screen. An EEG will confirm electrical activity, but this might result as normal if it's in between seizures. So if a patient has a seizure with you in the room, you want to maintain safety. We're going to pad the bed rails. We're going to have suction and oxygen nearby. You never leave a patient who is actively having a seizure. You want to call for help and remain calm. Once the patient starts seizing, you want to take a look at the time and make a mental note or write it down. Medications. Patients may be on different anti-seizure meds such as Keppra or valproic acid, so you should know what those side effects are. Status epilepticus. This is a life-threatening condition, and by definition, if a patient has a seizure for more than 5 minutes, or if a patient has a seizure back-to-back without returning to their baseline, this is considered status epilepticus. So again, it is life-threatening. If a patient begins to seize more than 5 minutes or has 2 seizures back-to-back and does not return back to their baseline in between, you will need to call a rapid response and get help immediately. You are going to prepare for IV benzos or a loading dose of anti-epileptic drugs. The nursing relevance here. It is our job to prevent injury, to support the patient's airway, to administer medication, and to give the provider the best data to work with. Let's review seizure precautions. Now this picture is a great example of what you should and should not do. So we have a patient lying in bed. The bed is in lowest position. There are 3 side rails up and padded. We have suction and oxygen available at the bedside. We have provided privacy as soon as possible. That could mean drawing the curtain or closing the room door. And the patient has loosened clothing. So very important, during a seizure, what not to do. You do not want to place anything in the patient's mouth. No tongue depressor, no spoon, nothing. You don't want to hold the patient down, so we're not going to restrain them. You can injure yourself and you can injure the patient. You do not want to keep the patient supine. So supine means they're on their back. We don't want to do that. We want to turn them to their side. And this is so they don't aspirate on saliva, their vomit, or just any secretions. So nursing relevance here. Your calm presence makes a huge difference. Family members, visitors will often panic. So you remain calm, you keep the patient safe, and you remember what time that seizure started. Our final nugget for seizures. Seizures happen when there's abnormal electrical activity in the brain, so you can think of it kind of like a short circuit. They can look different depending on the type, but safety is always the priority. As a nurse, remember to protect the patient, never restrain them, note the timing and characteristics, and you're going to keep the airway clear. After the seizure, you're going to support recovery and reorientation because the patient will be fatigued and often a little disoriented. Quick thinking and calm action makes a huge difference. Thanks for watching. If this helped clarify things for you, be sure to like, comment, and subscribe for more Med-Surg knowledge nuggets just like this one. See you in the next video.